A 70-year-old female patient, Mrs. Charlotte, is brought into the emergency unit by her family in their private car. She presented with rigors, vomiting, and confusion. She only started getting ill about 5 days ago, though it initially started as a minor medical complaint. But now, what seemed to be a minor condition has turned into something which is life-threatening. And the question is, what is it? Have you ever imagined how many times in your life have you had infections, but for some reason your body was able to clear them, and sometimes without taking medication? But unfortunately, in some patients, the infection gets out of control and turns into what we call sepsis. Hi, you are watching ED Files, and I am Dr. Thabo Mafa. And now, what is sepsis? This is a life-threatening medical condition that results from a dysregulation or an abnormal response of a patient's immune system to an infection, and this can lead to organ damage or even organ failure, and furthermore, it can result in death. It starts as a local infection that remains uncleared for a while. The pathogen, or the bug, therefore gets access into the bloodstream, whereby a cascade of events starts taking place. It first starts as an inflammatory process in an attempt to control the infection in your body, and therefore it is followed by an excessive release of a chemical into your bloodstream, and this is nitric oxide. It is released from the walls within your vessels. What happens thereafter? There will be dilation of your arteries and veins, and by doing that, the pores which are found on your vessels start making the fluid to leak into the tissues. This will therefore, in a way, result in less fluid within your vessels and reducing the pressure which is found in your vessels. And in return, that would result in a systemic drop in your blood pressures. Another process that takes place in this case is there will be formation of small clots within your small vessels. And because of this process, which we call coagulopathy, there will be formation of these clots, and the cells which are supposed to be helping you not to bleed easily are all absorbed or clamped into those clots. This would, in a way, make the patient vulnerable to bleeding. They bleed easily in most cases. But now, what about Mrs. Charlotte? What is it that we found when we examined her? Her blood pressure was very low. It was 75/40 millimeters of mercury. And she had tachycardia, fast heart rate of 130 beats per minute. Her temperature was high, 39.5 degrees Celsius. And her estimated body weight was around 80 kilograms. She looked acutely ill, breathing fast or hyperventilating. And in most cases, the normal respiratory rate of an adult is around 12 to 20 breaths per minute. In the case of Mrs. Charlotte, her breathing rate was around 29 breaths per minute. The paramedics had already put up an IV line or a drip. They gave her about 1.5 liters of Ringer's lactate in an attempt to improve on the blood pressure that she was having. The chest was clear bilaterally when I listened to it, and her heart sounds were normal. There was nothing of note on the heart sounds, including the ECG that we had. The only thing of note was a sinus tachycardia of about 129-130 beats per minute. On the abdomen, she had bilateral flank tenderness and also the suprapubic area. That made me suspect that possibly there could be something going on in the abdomen or in the urinary tract system. We also had to check for signs of meningitis, but none of those signs were present. Even though my suspicions were that she could be having something in the abdomen or in the urinary tract that's giving us all these symptoms and signs, we still had to do some investigations. And what is it that we've done? We did an arterial blood gas, and on it we found that the lactic acid levels were very high. Lactic acid usually picks up whenever there is severe infection going on in your body, and it can be used as one of the markers to look at whenever you are monitoring response to treatment. We put in a catheter. An adult should give you urine output of about 0.5 to 1 ml per kg per hour. And that would translate to, in the case of Mrs. Charlotte, because she is about 80 kilograms, that would give you something like 80 ml per hour. But because of the condition that she had, which was really not giving us a good urine output, she only gave us 20 ml of urine. So as you can imagine, it will mean that she's not putting out enough. And the kidneys in that way could be at risk of shutting down. We've done a urine dipstick after putting in a catheter. And the markers that we looked at were the blood. She had 3 plasmas of blood in the urine. She had leukocytes, and these are cells which are indicative of infection. She also had nitrites, which were positive in the blood. And the color of the urine was very cloudy and also looked a little bit like pus. And we've done some bloods. We've done a white cell count which was very high. Her C-reactive protein was about 400. And we've done a kidney function test which showed mild derangements. And we've also done some liver function tests. We've done PCT, which is more specific in bacterial infections. And it was sky high as well. Furthermore, we've done a chest x-ray. It was clear there was nothing of note on the chest. So, what other investigations can you do in a patient in that condition? We've done a CT scan of the brain. Remember, Mrs. Charlotte presented with confusion, so you need to make sure that there's nothing in the brain that's causing all these symptoms. We also did a lumbar puncture to exclude meningitis, but none of those investigations were abnormal. Furthermore, considering that she presented with rigors, these are excessive body tremors which would be a response to fever in most cases, or the toxins that are released by the bacteria or whatever bug is in your system. So we had to check if she doesn't have malaria. We've tested for that, but it was also negative. We've done blood cultures, but remember these ones take about 24 to 48 hours to come out, depending on what laboratory you are using. But now remember, if a patient has got a condition that is threatening their life, you need to be aware which organ is most likely to be affected. And in this case, there are target organs that we need to monitor. And these are the cardiovascular system, the respiratory system, the liver function. You also have to check the neurological system and also the blood, what we call the hematological system. Remember, with the hematological system, you're looking at the infection markers and also the tendency for the blood to form clots and to bleed. With the cardiovascular system, remember, there is a decrease in heart activity, or the heart is unable to pump blood as it used to. And on the other hand, the vessels are getting bigger, getting dilated, with extravasation of fluid or the leaking of fluid into the tissues, with low blood pressures as well. With the respiratory system, a patient can easily go into respiratory failure. Mrs. Charlotte came in hyperventilating, which means if we don't take care of the infection, she can easily go into respiratory failure. You also have to look at the liver function test. Now that we have done some examination and also did some investigations for Mrs. Charlotte, perhaps you could be asking yourself, how does a patient end up with sepsis? There are mode of transmissions or mode of infection that could possibly lead to sepsis. And one is lower respiratory tract infection. A patient with lower respiratory tract infection could have an infection that is not so well controlled, and eventually the bug or the pathogen gets access into the bloodstream and causes sepsis. Secondly, you could have abdominal causes, or a urinary tract infection can also do that. You could have a patient who's been pricked with a needle, for instance, that is contaminated with a bacteria or a virus, and that would cause a direct spread into the bloodstream, and that is a hematogenous spread or access into the bloodstream. What is it that can make a patient susceptible to sepsis? Remember, we said that at some point in our life we get infections, but that does not necessarily become sepsis. And these are the risk factors: the extremes of age, the very young patients, and also the very old patients, usually about the age of 65. Patients whose immune systems are not optimal, and that is immunocompromised patients. It could be from HIV-related diseases or AIDS, or also cancers. And even uncontrolled diabetes can put you at risk of having sepsis. Patients who are on cancer treatment also, their immune systems are a little bit compromised, and that puts them at risk. We can have procedures also that we do in hospitals, and especially if the instruments are not being sterilized, a patient could have sepsis from that. An example of those is putting in a central venous line, a urinary catheter, and also a drip. So the other thing that people might not be really comfortable about when I say it is excessive alcohol consumption, which is one of the beverages that we know that most people like, but an excessive consumption of it can put your life at risk in terms of sepsis. And for pregnant women, they need regular checkups and early treatment of infections so that it doesn't end up with sepsis. How do we then treat a patient in this condition with sepsis? Remember the signs, the symptoms that we had. we have to make sure that each and every ailment is attended to. She had fever, so it means we have to take down the temperature. She had vomiting. It means we have to stop the nausea and the vomiting. She was confused. It means we have to treat the main source of the confusion, in this case, which was severe infection that led to sepsis. So we need to commence antibiotics as soon as possible. We first start with a broad spectrum antibiotic. Reason being that blood cultures, which are more specific in terms of which bug is causing this problem, they come a bit later. So we cannot really fold our hands, wait for the next moment, or wait for the next 48 hours before we start treating. So start first with the broad spectrum antibiotics. And thereafter, you will narrow down to the specific antibiotic based on your cultures. The patient also had low blood pressures. What do you do with that? You need to give them fluids to improve on the blood pressures. But at the same time, you have to do it carefully so that you don't overload their system and they end up with pulmonary edema, that's lung congestion with fluids. You may have to consider inotropes at some point, and in most cases we'd use adrenaline infusion or Dobitrex infusion. So after all the examination and investigations that we have done, what do we therefore conclude or come up to in terms of the condition? In this case, Mrs. Charlotte, a 70-year-old female patient, had sepsis. And to be more specific, this was septic shock. And this means her cardiovascular system, which is the heart and also the vessels in the body, were unable to compensate for this infection. The blood pressures dropped drastically. And this sepsis was as a result of urinary tract infection, which had ascended to the kidney level, and we call it pyelonephritis. Perhaps now you are asking yourself what eventually happened to Mrs. Charlotte, an elderly lady who came in with confusion, vomiting, and also high temperature. The outcome was that she was stabilized in the emergency unit. Her blood pressures had improved. Temperatures came down to 36 degrees Celsius. She was taken to ICU, where she made a speedy recovery. And in conclusion, while most of us would have infections in our lifetime, these infections could clear easily, but unfortunately in some patients, like those that we've mentioned with risk factors, this infection could lead to sepsis, which can be deadly. So, early recognition of the signs and symptoms of sepsis, and also commencement of treatment as soon as possible, can save a patient's life. And thank you for watching.